Hello everyone. Today I am going to teach you about the shoulder joint. Shoulder joint is one of the important topic in exam as well as in our practice. In our practice, we see the cases like dislocation of the shoulder joint, frozen shoulder. Okay. Now we will discuss regarding the shoulder joint type. It is the synovial joint of the ball and socket variety. Articular surface. As you know, the joint is formed by the articulation of the glenoid cavity of the scapula and the head of the humerus. Therefore, it is also known as the glenohumeral articulation. Structurally, it is weak joint because the glenoid cavity is too small and shallow to hold the head of the humerus in place. The head of the humerus is 4 times larger than the glenoid cavity. Due to this arrangement, great mobility is possible of the shoulder joint. Now, stability of the joint is maintained by the following factors. First, coracoacromial arch or secondary socket. In this diagram, you can see the coracoacromial ligament, coracoacromial arch. Second, musculotendinous cuff or shoulder joint. It is also termed as rotator cuff. It can be asked in Viva. Rotator cuff muscle. Okay. These are supraspinatus, infraspinatus, teres minor, and subscapularis. Okay. The glenoid labrum helps in deepening the glenoid fossa. In hip joint, we have seen the acetabular labrum. Okay, which is attached to the margin of the acetabulum. Like that, glenoid labrum is also attached to the margin of the glenoid cavity and helps in deepening the glenoid fossa and hold the head of the humerus. Okay, I am repeatedly telling in the class or giving instruction in the class that whenever you study the anatomy, you have to compare the you have to study comparatively anatomy. Like now we are studying shoulder joint, so that at that time we have to remember the hip joint, that so we can easily remember the topics of that joint. Now fourth one is stability is also provided by the muscle attaching the humerus to the pectoral girdle, like long head of the bicep brachii, long head of the tricep, and fifth one is atmospheric pressures. Once again revising: coracoacromial arch, musculotendinous cuff, glenoid labrum, muscle which are attached to the pectoral girdle, atmospheric pressure. Now we will discuss regarding ligaments. First one is capsule of the shoulder joint. Okay, it is very loose and permits freely movement. It is least supported inferiorly where dislocations are common. Also we have discussed that head is 4 times larger than the glenoid cavity. Such dislocation may damage the closely related axillary nerve. Okay, there is a course of the axillary nerve, so if dislocation inferiorly occurs, then there will be damage of the axillary nerve. Now we will discuss regarding the attachment of the capsule of the shoulder joint. Medially, beyond the glenoid labrum, supraglenoid tubercle, laterally anatomical neck, inferiorly surgical neck, superiorly it is deficient and give passage for the long head of the bicep brachii muscle. Also, the joint cavity communicates with the subscapular bursa with the synovial sheath for the tendon of the long head of the bicep brachii and often with the infraspinatus bursa. Anteriorly, the capsule is reinforced by the supplemental bands called the superior, medial, and inferior glenohumeral ligaments. Okay, in this diagram, you can see superior glenohumeral ligament, medial glenohumeral ligament, and inferior glenohumeral ligament. The capsule is lined with synovial membrane. An extension of this membrane forms a tubular sheath for the tendon of the long head of the bicep brachii. Okay. Now we will discuss regarding coracohumeral ligament. It extends from the root of the coracoid process to the neck of the humerus opposite the greater tubercle. It gives strength to the capsule. In this diagram, you can see the coracohumeral ligament is attached from root of the coracoid process to the neck of the humerus opposite the greater tubercle. Okay. Transverse humeral ligament. Okay, it bridges the upper part of the bicipital groove. It is also termed as intertubercular sulcus between two tubercle, greater tubercle and lesser tubercle. The tendon of the long head of the bicep brachii passes deep to the ligament. Between greater and lesser tubercle, there is a tendon of the long head of the bicep brachii, so it is also termed as bicipital groove. So transverse humeral ligament bridges the greater and lesser tubercle. Okay, and lodges below it. There is a long head of the bicep brachii, tendon of long head of bicep brachii. Now, glenoid labrum. It is fibrocartilaginous rim which covers the margins of the glenoid cavity, thus increasing the depth of the cavity that we have discussed. Okay. Glenoid labrum. Bursa related to the shoulder joint. The subacromial bursa, the subscapularis bursa communicates with the joint cavity. The infraspinatus bursa may communicate with joint cavity. Several other bursae related to coracobrachialis, teres major, long head of tricep, latissimus dorsi, coracoid process are present. Okay. In this diagram, you can see subcoracoid bursa, subscapular, subacromial bursa. Okay. Relation superiorly coracoacromial arch, you can see also in the diagram. Subacromial bursa, supraspinatus, deltoid, inferiorly long head of tricep, anteriorly subscapularis or coracobrachialis, bicep short head, deltoid, anterior fibers, posteriorly infraspinatus, teres minor, deltoid, and within joint long head of bicep brachii tendon. Okay. Now, blood supply. It is supplied by the anterior circumflex humeral vessels, posterior circumflex humeral vessel, suprascapular and subscapular. Easy to remember: anterior and posterior, supra and sub. Okay. Now supply axillary, musculocutaneous, suprascapular now. Okay. Movements at the shoulder joint: flexion, abduction, adduction, lateral, medial rotation and lateral rotation, circumduction. The shoulder joint enjoys great freedom of the mobility at the cost of stability. There is no other joint in the body which is more mobile than the shoulder. This wide range of mobility is due to laxity of its fibers, capsule, and large size of the head of the humerus as compared with the shallow glenoid cavity. The range of the movement is further increased by the concurrent movements of the shoulder girdle. In this diagram, first flexion, second extension, third abduction, fourth adduction, fifth medial retrotation, sixth lateral rotation. Okay. Now muscles which produce the actions: flexion, pectoralis major, deltoid, accessory muscle, coracobrachialis, biceps, short head, extension, deltoid, posterior fiber, latissimus dorsi, accessory muscle, teres major, tricep long head, pectoralis major, sternocostal head, adduction, pectoralis major, latissimus dorsi, biceps long head, triceps short head, accessory muscle, teres major, coracobrachialis, abduction, supraspinatus, deltoid, serratus anterior, trapezoid, upper lower fibers. Okay. There is written like 45 to 60. It indicates the degree. Okay, 45 to 60 degree, 0 to 135. Okay, 90 degree. Now lateral rotation, 70 to 90 degree, deltoid, posterior fiber, infraspinatus, teres minor. Okay. Now we will discuss interesting topic, applied anatomy of shoulder joint. Dislocation of the shoulder joint is common. The shoulder joint is more prone to dislocation than the any other joint. This is due to laxity of the capsule and the disproportionate area of the articular surface. Dislocation, it means we have discussed that head is 4 times larger than the glenoid cavity. Dislocation usually occurs when the arm is abducted. In this position, the head of the humerus presses against the lower unsupported part of the capsular ligament. Dislocation endangers the axillary nerve, which is closely related to the lower part of the joint that we have seen. Optimum attitude. Okay, in order to avoid ankylosis, many diseases of the shoulder joint are treated in an optimum position. In this position, the arm is abducted by 45 to 90 degrees. Shoulder tip pain. Okay, irritation of the diaphragm from any surrounding pathology causes referred pain in the shoulder. This is because of the phrenic nerve which supply the which supply and the supraclavicular nerve supplying the skin over the shoulder, both arises from the spinal segment nerve. So whenever the tip pain at the shoulder joint, we have to means differential diagnosis that is it maybe due to that or what. Okay, differential diagnosis is most important factor in practice. The shoulder joint is most commonly approached from the front. However, for the aspiration, the needle may be introduced either anteriorly through the deltopectoral triangle or laterally just below the acromion. Now, what is deltopectoral triangle? It is a triangular depression formed between the clavicle above, laterally border of the pectoralis major, medially, and the medial border of the deltoid laterally. Okay, it contains our clavipectoral fascia, cephalic vein. Okay, frozen shoulder. This is common occurrence pathologically. The two layers of the synovial membrane become adherent to each other. Clinically, the patient, age between 40 to 60 years, complains of progressively increasing pain in the shoulder, stiffness in the joint, and restricted movements of the shoulder joint. The surrounding muscles show disuse atrophy. The disease is self-limiting and the patient may recover spontaneously in about 2 years. It means it will be recovered by self. Okay, so here we have finished shoulder joint. Thank you everyone.